this on my computer. Gallery view. Okay. Hello, everyone. This is presentation on tummy time and the management of torticollis. I'm going to wait and see if a few more people join us, and then we will get started. If someone could make sure if you can hear me, would somebody put in the chat that you can hear us as we start talking? Great, thank you. Yay. I will say as a preamble, this is the first time that Erin and I have done this, so it may be a little glitchy. Information's great, but the management of the technology could be a little glitchy, so hang with us as we go through our presentation today. The subject, it's sort of a combination subject. I'm going to start out talking about tummy time, and then she's going to take it over giving us some information about torticollis. We will have time, should have time for questions, and we can answer them as we go or at the end. And if you'll type them in the chat, we'll try to monitor that and answer them at some point. Good. So technically, it's time to start. I'm sure a few more people as they grab their lunch will join in with us today. For those of you that you don't know, that I'm Gail Fennimore, and with me here is Erin Ogden. She is a Doctor of Physical Therapy student from the East Carolina University and is interning with Child and Family Development. This is her last week, and then she'll be graduating in May. She is the one most responsible for this PowerPoint presentation. I am a longtime physical therapist, many decades of experience in treating children. Like I said, we're going to spend some time talking about tummy time in general, and then we're going to talk a little bit about torticollis in particular today. We will, and then we'll answer questions as we go along. I'm going to share my screen. This is where the part gets a little iffy, so hang with me. Good. Okay. Can you see? That looks good. I can't really see anything until I move out of this screen. So
you can see the whole, like the presentation and the notes.
Okay. Well, let me move to the other.
There you go.
There you go. Okay. Got it. Now, this says, so we're going to start with gravity. Gravity is, the definition here is the force that attracts a body toward the center of the earth or toward any other physical body having mass. And the problem when we're talking about children, infants in particular, is that it's not a strong force, but it is a constant force. Let's see if I can, and now I've got to get my coordination together here. How do we balance the effects of gravity? And the way we balance these effects is variety and positioning. And I will say as a caveat that many of the slides today are courtesy of my grandsons and a few close friends. But we vary positioning by being held, being carried, napping, how we, when we're changing diapers, how we play, and how we feed. And throughout the presentation, there are a fair number of pictures that show different examples of this. So there, are many positions that infants can be placed, but parents have a tendency to lay their babies on their back a lot. They see that as a safe position, especially with the back to sleep campaign, or they're in their car seats or stroller, which are often your car seat on just wheels, rock and play type hammocks or other types of sitters. And each of these has a strong passive effect of gravity on a baby's head. And that's one of the things that we want to vary that effect of gravity on the baby's head. Let's see if I can move this on. So here are some different positions that we we're going to be moving to. Oops, I think let's see, skipped ahead or not. So here's just a collection of different babies in different positions. Some are quite funny, with Charlie in the center as he's all snuggled up in the dirty laundry basket, and thinks it's quite delightful being bound in that little space. We have Gray over here propped prone over a boppy, and boppy is one of my favorite positioning devices that you saw before with Charlie on his napping on his side. Down here we have a sweet girl on just a baby quilt on her mom's lap as she naps. Over here on the upper right hand corner, we have a Thomas totally racked out over his granddad's lap as he takes a nap. And then another sweet one just snugged up against the back of a couch as he's laying on the side. These all qualify as sort of tummy time opportunities. And then the other part of balancing the effects of gravity is movement, and we get a variety of movement in how we rock our babies, how we hold and rock them, how we bounce them up and down, rolling with them on the floor, tilting them in space, and just having a lot of variety of movement dealing with gravity in different ways. Let's see, let's go on. Here's one, weight bearing on, in all of these positions, when you have a variety of positions, you have a variety of weight bearing on muscles and joint surfaces, and all of that helps to build strength, muscle strength to move up against gravity. And the whole purpose in development of skills is to be able to move up in gravity. So weight bearing on muscles, as the slide says, wakes them up. Pressure on surfaces gives awareness of where your body is in space and helps to organize your entire sensory system. And being on your tummy helps a baby to integrate their moro or startle reflex and readies them as they move up against gravity. And in a startle reflex, you know, a baby's arms will fly out from their side and they look very startled. And it's very easy to elicit when they're on their back. One of the things, and it does tend to go away by 3 to 4 months, parents often are taught to swaddle their children from birth as a way to manage the startle response and to help sleeping. But spending waking time on their tummies will also help to accomplish this same thing and helps them develop more muscle strength and skills. So we suggest tummy time instead of swaddling, especially for awake time. And they are swaddling for sleep is fine, but it's not always the most effective way to quiet babies. Okay, here we go. So a little bit about the benefits of tummy time and the effects of too little. When you have too little tummy time, and babies spend a whole lot of time on their back or on their are even semi-sitting like in their car seats, their tongues are pulled back in their mouth by gravity. And that can lead to some decreased efficiency in sucking. There is being on your back a lot can increase the severity of reflux. The tongue in the back of the mouth is sort of a constant place that it hangs out because of their positioning early in childhood, can actually is a risk for picky eating later on because the children aren't quite as adept at bringing their tongue forward for different kinds of eating, and they sort of feel like they have a gag, I'd say a heightened gag response. The other part of the effects of too little tummy time is you have a strong tendency toward a misshapen head and either plagiocephaly or brachiocephaly. And this is something that Erin is going to talk a little more about, and we have some slides showing later on, but just the constant effect of gravity on that soft baby's head can form some flattened areas that can be problematic. And of course, torticollis. There is also evidence that the less time you have in a variety of positions, and I include side lying with tummy time, is that you have slower development. Rolling, sitting, transitions in and out of sitting, and even walking. With tummy time, you're providing valuable input, as the slide says, into the face that helps with feeding and speech. Children who spend more time on their tummy in the first 3 to 4 months will be ready to move on their own sooner. It also helps to organize the digestive system, limiting reflux because it helps the organization and strengthening of the sphincter at the bottom of the esophagus as the rib cage comes down and has pressure on the area. Just lying on your back is in general just a much more passive position than on your side or your stomach. Let's go next. Okay, Erin's going to take over with Erin. Can you see the chat from where you are or not?
Yeah.
Okay. Are there any questions or anything?
No, not up there so far.
Okay, so Erin's going to take over now and talk a little bit about torticollis, and then and if there are any questions, we'll answer them. Go ahead.
Okay, so torticollis is normally described as a unilateral shortening or potential fibrosis of the sternocleidomastoid muscle, which we'll refer later in the PowerPoint as the SCM. And this usually causes an asymmetric posture of the head and neck, which you can easily see in the picture on the right of your screen. That's actually one of our current patients that we have just seen. You can tell that she's looking right and she has that left head tilt. And it normally is seen with a lateral flexion of the head, which is that tilt component, usually occurs towards the affected muscle, and a rotation to the opposite side, which we'll explain later. And right rotation and left tilt is the most common presentation, which is what you see in the picture. It's usually caused by intrauterine position, large birth weight, post-birth due to positioning and possible trauma. And the incidence is as high as 16% of births. So talking about tummy time and how it's beneficial for all children is super important, no matter what the kid is. But specifically in this presentation, we're linking the importance of tummy time to how it relates to torticollis and how we can help prevent that. So the types of torticollis, there's actually multiple types, but these are the two that are most common.
Oops.
Gail, you keep going forward.
I'm sorry. Excuse me. Let me Give me just a second.
Yep.
I skipped. It's slow to move back. You want to be there, or am I on the right slide?
Yep, this will work.
Okay, thank you.
Okay, so the two main types of torticollis is congenital muscular torticollis, and this basically means that it occurs prenatally or at the time of birth. Some of the most common causes are fetal malposition, uterine compression, birth trauma, or an ischemic event involving the SCM, which means that that muscle briefly lost oxygen. It also may be accompanied by cranial deformation, which is the plagio and brachiocephaly that Gail mentioned before. It also may be accompanied by hip dysplasia or a possible brachial plexus injury, or even distal extremity deformation. And then, so about the SCM, sometimes when there is an ischemic event and it loses its oxygen supply, it often comes out with a thickening bulge in the muscle that almost kind of feels like a tumor. But with therapy and soft tissue work, that usually resolves on its own. And then the congenital one, meaning that it occurs prenatally or at the time of birth, those are usually prevalent sooner in life and are able to be recognized sooner than the acquired torticollis. So the acquired torticollis means that it occurs postnatally and is often caused by a simple limitation of the range of motion of the neck, which leads to the typical head tilt seen. And then non-muscular causes account for about 18% of all cases and include a cervical malformation, subluxation of a vertebrae, a possible tumor, reflux, which we hit on before, clavicular fracture, or a possible brachial plexus injury. So with reflux, the way that this can cause a torticollis is because the child will position themselves in a way to where it like avoids the pain or possible discomfort from the reflux, which puts them at risk for a torticollis and that muscle shortening on the side. So why is this so serious? Torticollis can occur in isolation with no other conditions. However, it can also occur with other types of malformation, the most common being plagiocephaly, which we're going to get into on the next slide. So plagiocephaly is the deformation and flattening of one side of the head by continuous application of an external force. So if you see in the picture, that's your normal head alignment. And then the right picture is plagiocephaly head alignment. So you can see how just by flattening one side of the back of the head, it kind of makes everything of the head misshapen. The ears are no longer aligned with each other. The eyes are no longer aligned with each other. You can actually have, in severe cases, where the forehead and eye will bulge on one side. And then some of the risk factors for this is first birth, assisted labor, meaning the use of a vacuum or forceps to help with the delivery, multiple pregnancies, injuries from birth, congenital malformation, premature infants, boys are more likely, muscular torticollis, and then too much supine positioning, so too much back time. And misshaping of the head can lead to a torticollis, or a torticollis can lead to the misshapen head. In therapy, it's kind of like the chicken or the egg. We don't really care which one comes first because we're just going to treat it the same way anyways. So the dynamic duo of torticollis with plagiocephaly. When they're both present together, each condition kind of seems to exacerbate the other, meaning if they have a torticollis and are right rotated and left tilted, then they're going to stay on that right side more and stay to their preferred side, which could lead to even more flattening of the skull. And if they have a plagiocephaly, then they're going to have that flat spot and kind of rest in that position, giving that muscle even more time to shorten, which could possibly cause a torticollis. So it has been studied that when both are present, delays in both motor and cognitive development can be seen and can persist even up to 36 months. So 3 years. Imagine how much development occurs from birth to 3 years old, and all of that could be delayed in some shape or form due to these muscle tightnesses or a misshaping of the head. So this was not really too high on anybody's radar until the Back to Sleep campaign, which came out in 1992. And it was originally launched to help decrease the incidence of SIDS. It did its job, that's for sure. The incidence of SIDS decreased by more than 40%. However, the rate at which positional plagiocephaly was being identified increased by about 600%. So some of the studies I read was in 2002, the annual referral rate for plagiocephaly was about 50 referrals per year. And in 2014, it had jumped to 307 per year. So just looking at those statistics, I can't imagine what the incidence is now. I did not look at current research, but I'm assuming that it's either higher or it's about the same rate.
And I'll jump in here for just a second. You know, usually if it's mild, there are ranges, and we'll get into that in just a minute. But not all have to be treated for the plagiocephaly alone. But if it's a mild issue, but many do. Here we go there.
So due to the rising referral rate and incidence of both of these conditions, some pediatricians have released this new campaign highlighting the importance of Back to Sleep to prevent SIDS and keep those rates low, especially at an early age, but also supervise tummy time to avoid these positional deformities. So they really stress, yes, Back to Sleep to prevent any kind of sudden infant death at night, but supervised tummy time is a necessity to all babies, no matter if they have any kind of condition or they're normal developing. Tummy time is very important.
And we chose these pictures because these are very young infants, just a few weeks old. And in the far right one, where I think this is my grandson Charlie, you can see he is about 3 weeks old in this age, and he's already working on tummy time. He's already extending his legs and lifting his head in a very active, very again, and working against gravity. But these are really effective ways to place children on their tummy, and the fact that they don't like it is not really a very good excuse. Okay.
So now we're going to go into a little bit of how we as physical therapists assess torticollis. So through the examination process, we usually try to examine the child in all 4 positions. So laying on their back, prone, on their tummies, seated, and standing. And this just allows the PT to look at all sides of the head, from the anterior, posterior, lateral, and even an above view of the head to see of any deformities or malformations that have formed. You're also looking for asymmetries. So you can look for static asymmetries, which include like facial features, looking at the eyes, cheek, and ears to see if they're even, head position. That's mainly looking at their preferred head position in all of these resting postures, shoulder level, trunk position, pelvis level, and leg position. And some of the active asymmetries that we might see are movements of the head, arms, legs, and trunk. So some of the red flags that you want to be on the lookout for are things like suspected hip dysplasia, abnormal tone, late onset of a torticollis or plagiocephaly, and that usually ranges for 6 months or older, and visual abnormalities. So vision is, when I first came into this clinical, I didn't really think about vision as a big thing that we looked at in pediatrics, especially in children, like young children. But Gail thankfully explained to me that vision is very important to look at, especially when you're talking about the time they are spending in that preferred position. You want to treat it early because your main worry is that if they spend too much time in that position, their brain will actually set their new horizontal at something that you and I don't see as horizontal, which could just set them up for even more troubles later in their life. And then, so we always want to measure range of motion and tilt in all positions, which we'll see in the next slide. So this is another one of our little kiddos that we've been seeing while I'm here. I'm actually doing my case study for my class after this clinical on this little girl. And this just kind of goes to show you why we as physical therapists look at their head tilt and rotation in all positions, because the rotation and tilt may vary depending on what position you get them in. So we actually saw more of a tilt in our other little kiddo that you saw in one of the prior pictures. But with this one, some of the things to notice. So in the sitting one, you can tell her left shoulder is a little bit more hyped in this position, and she has less space on the left side of her neck than she does on the right, which means that the left SCM, sternocleidomastoid, is a little tight, and she's kind of scrunching that up. And you can also see that with her on her back. And this is kind of where you look at the active asymmetries in her motion. So if you can't really tell where her legs are, but you can tell that her left leg is kind of scrunched up a little bit in the flex position. And you can also look at her arm, how it's more hiked up here. And that's normal to see. However, that's something that is very important to pay attention to. And that's something that we look at, and that may be harder for parents to see because it is so minor. But that's why therapy is so important, especially to catch it early, because even just small asymmetries like that can have major effects on their rolling development, their sitting development, and then move into walking development. And then if you look at, oh, go ahead.
No, go ahead, and I'll chime in a minute.
And if you look on while she's on her stomach, it's the same thing. Now her left leg is extended, which is good. When we first started seeing her, her left arm tended to be scrunched up underneath, and her elbow was behind her shoulder. And that was not allowing her to explore her environment while she was on her tummy. She wasn't able to reach. So she didn't like it because she wasn't able to interact with anything that we had in front of her because of that scrunched position of her arm.
I just wanted to say I want to applaud this mother because she also sent us 3 really wonderful pictures of the neat things that she's doing with her at home, seated in front of the mirror, having the mirror in front of her on her tummy and having her propped up a little bit. And Erin's point about the subtleties about what we're looking for is just extremely important. And this is a mild case of torticollis, but sometimes if you look in the sitting picture, her head is pretty straight. But if you don't notice that, she's actually getting that straight position by hiking her shoulder up. And if you look down at her hips, how much more forward her left hip is in this sitting position than her forward of her right hip. It is, and they just, these small asymmetries will just push you to preferences in how you move. Okay. Now, a few more things.
So we wanted to make a slide about things that parents might notice, because like we just made a point of in the last slide, how subtle the changes and differences that you can see, that parents may not be in tune to look that closely at their baby's movement. So if you can just simply look back at cute little baby pictures, because we know we all do that, you notice their head is always turned to one side, such as in this picture on the right. That's our other little kiddo that we see. I'm sure this mom has plenty of pictures, cute pictures like this, where she's like, wow, she's always tilting that head over to that side. You can also look at breastfed babies. They may have trouble feeding from one side. A noticeable flat spot on the head just behind one ear. Trouble moving head towards you, or getting frustrated when trying to turn their head in one direction. And then also a lump in the neck in the SCM, which is what we talked about, of that possible like fibrosis that would resolve with physical therapy and soft tissue massage. So the SCM muscle runs from behind your ear to the front of your like clavicle area. So the reason why the torticollis is named for the side that they're tilted to is because this muscle runs from here to here. So it tilts your head to the same side, but it rotates to the opposite side. So in this picture, she's tilted to the left, but she often rotates to the right. So her issue would be with her left SCM. So there are different classifications for torticollis, and Amy Sturkey actually brought this article that I got this information from to Gail's attention, and of course Gail sent it to me. It was a very interesting read, and I've never heard of this classification. They don't teach us this one in school yet. I'm sure it will come. But so type 1 is the most mild. You see a slight cranial asymmetry is completed, limiting to the back of the head. So nothing else is affected except the back of the head. Type 2 affects the central cranium and the skull base with minor displacement of the ear. So a facial, So then type 3 is a triad, which is posterior asymmetry, malalignment of the same side ear, and same side frontal bone protrusion causing a forehead bulge. So this is where you would see kind of the misalignment and of the ears, where one may be further back or in front of the other one. Type 4 is deformities of the posterior skull, malalignment of the ear, forehead protrusion, and a facial asymmetry. So with the facial asymmetry, this is usually the result of increased fatty tissue and not necessarily an overgrowth of the zygomatic bone, which is the cheekbone right underneath your eye. So that's the good thing about that, is because it's not a bony malformation, so it can be fixed if you fix the rest of the skull misalignment. And then type 5 is the most serious. You have all of the above deformities plus possible temporal bulging. And then it also leads to something more serious, which is a possible decompression of the brain due to the severe anatomical changes. So anything to do with the brain or possible compression of the brain is a big red flag, and that needs to be treated ASAP.
And then just a clarification, these are the classifications of plagiocephaly. I think I don't want to confuse you with, you can, torticollis can happen, remember, can happen alone, or it will happen in combination with plagiocephaly. And these are the types of skull cranial deformation that you can have. I think we might have said torticollis earlier. But next, let's see. It's gonna go. Okay.
Okay, so that brings us to treatment. How do we treat this torticollis and plagiocephaly? So a lot of it is counter positioning. So you can position them in any other way than their preferred direction. In more serious cases, you can do helmet therapy, which is recommended for moderate to severe cases of plagiocephaly, not so much the mild cases. If it's presented at an advanced age, then more than likely you're going to go with helmet therapy. And then for infants with persistent plagiocephaly after a course of conservative treatment, then you probably want to go with something more concrete as a helmet. And then something we actually learned just recently was an application of a helmet usually does not occur before 4 months of age. So one of our little kiddos actually got fitted for a helmet, but she couldn't get one because she was only 3 months. So that was an interesting fact that we learned. And then of course, physical therapy, manual therapy added to standard repositioning treatment. And in a study I read, this type of treatment is actually reported to reduce the whole treatment duration and has higher improvement rates in patients with severe conditions rather than milder forms, which is interesting. So you may, in more severe cases, you may still have helmet therapy, but all cases should be seen by physical therapy to help with the positioning and teaching of the parents. So you want to monitor movement and skill development to address or prevent possible asymmetries. And then of course, our big thing is parent education. So physical therapy can work on different positioning techniques with the parents during play, feeding, changing, and even sleeping, stretching activities of the tightened muscles, rolling to their non-preferred side, which is normally a big deal, stimulating play in all positions. So you want to give them visual cues and place them in positions that encourage them to look to their non-preferred side. Strengthening neck and extensor muscles. So a big thing to look at in these kids are how they're using flexion and extension. They're usually overusing one and are not able to blend them well, especially moving from transitions from laying on their back to sitting or standing. Improve postural control and symmetry. When we talk about postural control, we talk about it in the sense of all positions, so sitting, lying, tummy. And then small things make a big difference. So blocking their preferred position while they're in a car seat, as well as limiting time in the car seat and strollers. And the use of wraps and carry packs are ideal rather than strollers and car seats, just because it allows them to be in any other position than on their back. So this is a fun video that I actually just found of a friend's baby that I went to high school with. And you know, when you're about to graduate as a physical therapist, when you look at cute baby videos on Facebook and your automatic thought is, oh my gosh, this is so good for babies and their extensor muscles. So when I saw this video, this is actually one of the ways that Gail and I teach our parents to play and interact with their babies, is holding them in this position, because it forces them to kind of explore their environment, but also work on that extension in their back and their head, which helps strengthen. I mean, this is probably just as good as tummy time, especially if they tolerate that more than being on their stomach on the floor. So the main takeaway points from this whole presentation is request a referral to physical therapy from your pediatrician at the first sign of limitation in tracking deformation of the head, strong preference for certain head movements during positioning. Self-referrals are possible. Back to sleep, tummy to play is an essential part of early development for all children, and a variety of positioning and play is the spice of life.
Okay, I'm going to stop my share now and see if there are any. Don't look like there are any questions in the chat, but
There
if
is
anybody,
one.
oh, okay.
Logan asked, how much tummy time is generally recommended? What age should you start?
You start at birth. Over your lap, as you saw in the picture, any way you can. And it should be like a lot of their waking time. Napping is fine if they're in your presence, if they're over your lap, on your tummy, beside you on the couch. And then when they're awake, you can always, you saw several where you prop them up, and propping up helps them stay there, but it's never too early at all. Okay, if there are no more questions, then, oh, yeah.
What is an appropriate amount of
okay.
time for a baby each day in a positioner like a swing or rock and play style rocker?
My answer would be little snatches of time, 15 minutes here and there. The rock and plays have actually been shown to cause really significant brachiocephaly, which we didn't as much get into today, but that brachiocephaly is when the whole back of the head is flat. And it's not asymmetrical, but it's a symmetrical flatness. And they can be, that's just a lot of pressure on the head. But 15 or 20 minutes here and there is not going to make a difference. If they're sleeping, taking every nap that way, or they're that way for hours at a time while you oogling at them and cue at them, then that's a little too much. Okay.
Yep, I think that's
Thank
it.
you all so much for coming today, and we really appreciate it.
Thank you.